Good evening, everyone. Here Imran Abbas again. I am live from Dubai, and today we have Professor Ken Loi from Australia. Really, it is great honor for me to interview such a prestigious figure. So today we have, in my opinion, great opportunity to know more about Roux-en-Y gastric bypass. As you know all, so we have started this interview series with MGB OAGB that finished in June 2021, and we had some obsession. Then we continued this series of safe sleep gastrectomy. We have started safe sleep gastrectomy with Patrick Noel and end with Kazama Kazaruni, who is both are a well-known bariatric surgeon. And then we had some obsession of safe sleep. Now we have started Roux-en-Y gastric bypass, and we have started with a legendary bariatric surgeon, Professor Himpen, and that was amazing and definite. Today, I am excited to hear more about Roux-en-Y gastric bypass by Professor Ken Loi. I will not take more time. Sir, over to you.
Thank you, Imran. I'm really grateful for the invitations, and I have to say that at the moment it's 5 a.m. in Australia, so we're just waking up, and I think it's a great initiative. Everywhere in the world is ravaged by COVID. We can't get together, but we can still share some knowledge and experience, which is great. I think together, we can advance surgery afterwards. So I believe once all this virus settle down, our demand for surgery in the world is just going to go up to treat the disease. And so it's good to now getting ready, and especially for our junior doctors, to educate them why we are passionate about bariatric surgery. It's not cosmetic surgery. It's a proper upper GI surgery that can benefit a lot of people. So a bit about myself, I guess I'm down in Australia, in Sydney, and I've been doing upper GI surgery for the last 15 to 16 years. And I think when we first started, of course, when you train as upper GI surgeon, mostly what you're dealing with reflux and cancers and everything. But in fact, we are the first unit that really taking up bariatric surgery seriously, because at that time in Australia, I think there's only a few people doing the surgery, such as Harry Frydenberg and maybe Lillian, Jeff Hamdorf, and Jim Tooley, and a couple of the pioneer. And in Australia, I think most of the time when we first started learning bariatric surgery is lap band surgery. That's when I started to grow up with. But in America and also all over the world, it's different. Gastric bypass is the mainstay, either open, laparoscopic, even European. So we went overseas to learn the technique and bring it back. And I'll tell you a little bit more on my journey afterwards and how we discover ourselves. I have to say, I enjoy your sleeve series very well, because they're all big hitter, and my predominant surgery is still sleeve. But yes, in my experience looking at all the thing going on in Australia, I've been the treasurer for bariatric in Australia. I'm the current treasurer in Asian Pacific and the president-elect in about 2 years' time. I think Asian Pacific is like Middle East is an up and coming country. Our caseload is just going to go up compared to Americans and European. And we've got a lot to learn from each other, because our diet, our things, our multiculturalism in Australia, a lot of my patients are from the Middle East. And in fact, Australia is like a melting pot. So we deal with European people, New Zealand people, local Caucasian people, and Asian people. So we have to be very familiar with each culture, what they eat, because at the end of the day, it is a little bit about the food, but mostly about the operation. So Imran, ask away.
Sir, excellent, definite. And this is in my opinion, great introduction from your side. And as you have highlighted, so definite in Dubai, we have also faced different ethnicity. And that is, in my opinion, beauty of such a cities like Sydney and Dubai and many other cities. They host, I think, such a great population. Sir, we will go ahead. And so because we are surgeon, so yes, a person who has started more than 1 decade and doing bariatric surgery, now you are doing 16 years of bariatric surgery. Definitely, you you face some complication, you have some difficulties, and you evaluate your technique with the passage of time. You learn from your patients when you deal from different ethnicity, because at the end we deal with the food. Yes, we change, we face. So we are interested to hear from your side, because today we are talking about Roux-en-Y gastric bypass. Which points with the passage of time you learn and you evaluate your technique for better results?
Yes, it's actually changing a lot because we are the group that very early realized that left band can only do so much. And I guess it's only time that is proven that left band can only do so much. And not many people now are doing it in the world. In fact, in some places, I think the band is banned. That's what they call. but we still have some patients with left band that work brilliantly. So we're just telling you that not one operation fit well. So to increase our repertoire as a bariatric surgeon, nowadays we are not only learning endoscopic bariatric surgery, but also when we started, we went overseas to observe different people on the technique of the bypass. So when we bring it back, I still clearly remember when we first start doing it with circular stapler. Perhaps it's a stapler issue, probably it's a learning curve. You can have a significant amount of bleeding and stenosis and problems. So then we move on to hand sew, which of course, is tedious because at that time there wasn't any vlog and there wasn't anything that make life a lot easier. Perhaps also the camera, the lighting, etc. Every single case is a struggle, and the understanding and the suturing of the Pedersen space and the internal hernia space is often difficult and challenging. So after 2-3, we watch people doing bypass like Kelvin Heger can knock out bypass in 4 o'clock, 5 cases, no sweat, and go to the pub. And whereas when we come back, we say, how come we first start doing it? 2 of them is enough for us to sort of take a breath and go home and have a sleep. But with time, it is about, for young surgeon, don't give up. Laparoscopic skill is about repetitive training. You drive a car every day. You drive better when you are more mature, but as long as you're not speeding, you're fine. So that's just what the thing that we discussed just now in IBC about the energy device. So the company has made a lot of improvement in what we use day to day. The technique has changed in a sense that we're now moving, used to be from circular stapler, initially then hand sew, which takes too long, but it's a nice way to have it because it's always a skill that surgeon can fall back to now we're doing single posterior stapler and then closing up the defect with 2 V-lock joining up together in the middle, which seems to be working quite well for the gastroenterostomy. And also the enteroenterostomy, the lower down as well. Initially, I think when you try to controlling an organ called the small bowel, which move every time, and they're always not stabilized and they're always not behaving what you wanted to. And in a particular patient that your port side might not be advantageous, your skin wall is thick, the ergonomic is not right, and you're just struggling. So initially we do hand sew, but then now we'll do double stapling, providing you be careful and not narrowing the elementary limb. They usually go okay. So there's a lot of little tips and tricks and pearl, and each basically step of the bypass, we breaking down and teaching our 3 fellow. We routinely get 3 fellow every year. It's a step-by-step technique, approximately about 10 steps. So yeah, and everyone, if they practice on different step and each time, and when you add it all together, it will become a nice operations. Is that, what do you think?
Sir, excellent, sir. So I have a question. So you feel any difference between hand sewn and when you are started this linear stapler, especially marginal ulcer? Any difference?
Yeah, I do find that with hand sew, if it's unfavorable, even though they say that, I think the advantages of hand sew is you've got a narrower stoma and therefore you have good restriction because the food just stay in the pouch, provided your pouch is nice and narrow, which is what we tend to use, then it gives people more satiety, but the stenosis rate sometimes can be higher. So with the posterior stapler, I use a 30 millimeter stapler, And usually sometimes depending on the patients, you might not put the whole stapler in, you might just use 2 centimeters rather than 3. So it's almost equivalent to the size of the circular diameters of the new circular stapler, which I believe Bruno Dillerman doing excellent job on that as well when I watch him doing cases in Belgium. And I think with that less stenosis rate, patients tend to eat a little bit better. There's a little bit of less back pressures, especially for us is if, as you know, we're converting a lot of bypass band patient towards different procedure. And if you have experience with, I'm sure you have experience with band before, it's not the easiest to dissect the cardioesophageal junction where the folding of the stomach is. So your gastric pouch is often not ideal. And if you're choosing the stapler wrong, you can end up having very friable tissues, or the stapler on the top end on the cardioesophageal junction is not so secure. Then if you have a narrow stoma, the back pressures can actually causing leak, not on the top where the span scar tissue is. And we have a practice that with lead band, for example, if the patient suffer from massive reflux, either from the previous band or from de novo GERD or from hiatus hernia, etc., you A, have to fix up the hiatus, B, we don't try to do the procedure at the same time, based on the fact that we had a published paper that demonstrated in histological diagnosis that on the scar tissue on the stomach, if you come back in about 3 months, the tissues in where the band previous are, the scar tissue is much more pliable, and therefore the leak rate will be less. That's from sleeve gastrectomy point of view, but I believe it applies to bypass, to any single operation. You want your patients to be in the best condition to be operated on, and hence the safety of the surgery.
Excellent, sir. Excellent. Sir, according to your opinion, and we are interested to hear from your side, have you any age limit for Roux-en-Y gastric bypass in adolescents or in age more than 65?
I think, I think laparoscopic surgery, I do other surgery, I do a lot of hernias and also gallbladder as well, or even cancer surgery. Yesterday, in fact, I just done a laparoscopic evaluus. Both chest and the abdomen are laparoscopic. You can translate your skill to cancer surgery, because I do my esophageal gastric state anastomosis exactly the same like I doing my bypass surgery, with stapling and oversewing in the chest, not using the robot yet, but still laparoscopic. It's translatable. And let's say if you offer 93 years old patient that comes through your door with a laparoscopic cholecystectomy when you get a gangrenous gallbladder, in fact, age is probably not such a limit, but the caution fact is, if you know about the physiological thing of aging, there are some people that forever young, okay, they can operate until 90. But when you do get past age 65 to 70, muscle mass and also metabolic rate do drop off. So if you make a dramatic change to their in terms of caloric intake and other and nutritional issue, plus also their already existing comorbidity, you have to be really careful. You can A, carry them down through the surgery, B, in about half a year time, you don't have a patient that is wasted despite the disease is resolved and have a bad quality of life. So it's really down to the fitness assessment of the older patients. So my oldest patient is 73 years old. She's now 78 and she's still traveling the world and doing hiking. So, that's anecdotal maybe. That's for my older group. So if I can think that I don't cause too much problem to that patient and offer them good stabilizing or either resolving, not or controlling of their metabolic problem, I will have a go at that. So bypass, you may vary your lymph link in terms of your malabsorptive component, or if you're actually doing a sleeve, your volume or the bougie size may change a little bit based on what their day-to-day intake, what their dietary requirement, what their preferences of their diet to. That's my older group of patients. Now, in terms of younger patients, it's actually very interesting. Most of our surgeons here are pretty risk averse, so we don't tend to touch any bariatric patient or suggest bariatric surgery to any patient that is at least less than 15 years old. So I had a couple of the 16, 15 years old adolescent patients. Their parents had bariatric surgery. They are fully into it. They are well researched. They understand about it, the risk, and they understand the long-term things. But the operation we do for them still probably the sleeve gastrectomy. You might say that this is probably more radical because in fact, you take out the stomach, the bypass, technically you can reverse it. So you haven't actually cut out anything. But to cause such a rapid change to the hormone and also the rearrangement of the bowel, the longevity of the life, the future issue on pregnancy, since 80% of our patients are female. And I think we have to be a bit mindful about that. So my cutoff point, 15, 16 years old, provided they are mature, supportive family, don't have psychological Prader-Willi syndromes or etc. And I believe that they are good at follow-up as well, then I think I can offer surgery for them.
Sir, excellent. Sir, why I am asking this question in older age, because when we do surgery, any type of hypo-absorptive surgery, there is more chance of malnutrition. So then are you prefer to do sleeve, like just imagine 70 years old, but healthy, fit for surgery, but fit. There is no issue, and also no GERD, no issue maybe. So then you will select sleeve or Roux-en-Y in such a case.
I think it's depending on patient preference. I mean, I work with my patients. The main thing about being bariatric surgeon, I think, to people all over the world, initially you tend to stick to one procedures, but you have to keep an open mind, and there's never a procedure. I think the problem with lap band is the surgery is been told to a surgeon as a simple procedure. And so, people become a bit more fanatic on it. And when you're fully fanatic, you actually are blindsided by the science. And sometimes you have to look at, why you do bypass, sometimes why you do the sleeve, and sometimes patient acceptance as well. Even endoscopic bariatric surgery that is really popular nowadays, as we know, is that it seems to be minimal invasive, is the success rate may or may not match what bariatric surgery can offer, but it does benefit patient, and it might help the patient to gradually accepting the concept of bariatric surgery. Like we're about to publish our papers on my experience with gastric balloon for the last 5-6 years on carefully selected patients, that the success rate is reasonable, with only 4 or 5 patients that need to be converted to sleeve or bypass due to failure. But every single operation have the failure rate, and every single operation have a longevity issues. And as a surgeon, I always think that you always think of the next step, like Calvin telling, or the next guy that is doing the surgery. The Roux-en-Y gastric bypass is a well-researched, documented, standard operation. By the way, I haven't touched the limb length first. We'll get to that bit. We have made changes on that. But a standard Roux-en-Y operation is well accepted. So if patients understand about it, if there's no contraindication in terms of bad vitamin D deficiency, calcium deficiency, no Crohn's disease, no other major previous midline laparotomy that makes small bowel mobilizations difficult, we can consider that. But when you are 70 years old, there may be previous surgery happening. And I believe the tissue is also slightly different in terms of handling as well. So as long as you handle with care, a successful gastric bypass surgery can be offered. So I'm not objected to that, but yes, I'll be veering on the conservative side, possibly a sleeve gastrectomy instead.
Sir, excellent. Sir, during this, already you have touched regarding relative contraindication of Roux-en-Y gastric bypass. According to your opinion, what is relative or absolute contraindication of Roux-en-Y?
Yeah, we in IFSO APC was supposed to be in actually Miami last year, right? So now it's been put off, and we thought our session would do something interesting. So I set out 2 topics. The one topic to argue about or debate about is that is the age is a limit for the bariatric surgeon, because we have our, Dr. Freidenberg, who is very active, young surgeon, age, more than 75 or something like this, still operating every day. And we say that, when are you going to stop? We say, no, we're not going to stop. So, and then also, when should you start becoming a bariatric surgeon? When do you start really early and forget about all your general surgery and all your skill of lap chole and lap hernia? I still like doing variety of surgery, but if you're just becoming a bariatric surgeon, you might lose what's happening to the world and other things. So the next topic that we had was actually smoking versus chocolate. Which one is worse for the patient? So it's dietary thing and smoking. So smoking is kind of not my no-no, but we all know that the fact smoking actually is bad for any operation. So cardiac surgery, whatever it is, but particularly smoking, the toxic chemical that affecting the gastric axis secretions and the impairment of healing and the ongoing issue of stomal ulceration, you kind of take me back a little bit. So, and most of the smokers, they want an operation. So they will promise you they will stop. But unfortunately, the documented literatures probably will tell you that the relapse rate is almost up to 30 to 40%. So I think if they are, I guess I won't say that I won't operate them surgery, because if they have bad diabetic and bad metabolic problem, your benefit, you still probably be more outweighed than the risk. So, but they probably have to know that they stay on PPI. But one very interesting fact is the ulceration that leading towards permanent ulcer, that which I've excised a few and redo the anastomosis, is a combination of things. It's probably also vascularity, possibly the technique of surgery in terms of the pouch vascularity, where you staple, where you sew, plus the smoking. So you can't pin it down on all smoking in terms of when you have a marginal ulcers or anything. So whether you have a stomach exit or stomach pouch that is full of exit and that leading towards the small bowel ulceration instead rather than that. So there's a lot of variable, but we do have to pay more attention to smoker. And I'm pretty sure you share your experience in my Middle East cohort patients, and is in Dubai. So 2018, is that right? It's the first ever time I tried shisha in Dubai. So I have to say I quite enjoy it, but I do realize that how much more potent it is afterwards compared to smoking. I've declared not a smoker, but shisha is very social. So my Middle East patients always say that I don't smoke. I say, okay, what do? You do shisha. Okay. Let's have a conversation about that. This is more potent. You got to stop it. You can do it socially. You cannot do it consistently. Otherwise, why don't you take some PPI persistently, strucofate? I don't want to see you in the ER room with perforated ulcer, because the issue with pain is very interesting. Once the patients start having pain when they eat, they will start go to having over-counter medications. So the easy over-counter medication is Nurofen. In Australia, it's Nurofen, maybe possibly anti-inflammatory, neprogesic. So you actually have a self-perpetuating situation. So the more pain they have, the more anti-inflammatory, the more ulcer they have, the more pain they have. And we have converted a few mini bypass to full Roux-en-Y gastric bypass, because patients just been treating themselves. Once the patient get the weight loss, once the patient disease resolve, they do follow up with you less, and they might have gallbladder stone problem that come and see you, and they might have internal hernia pain here and there that cannot be resolved. They come back to you, but this sort of things you got to be careful. So careful warning that the patient need to tell them what type of bypass people had is also important, because I think in your country, am I right that I think the mini gastric bypass is the go-to operation at the moment, isn't it? Do you see that happening in your country, that patients with return problems that you require conversion?
Yes, sir, definitely. So we will also talk about this, sir. Regarding the smokers, because you have highlighted excellent point, because we have viewers from all over the world in global laparoscopy, and many of them, they are newcomers. They are going to start, or they are in early stages of this bariatric surgery journey. So I want to hear about, especially about smokers, because personally I feel many times, I agree with you, they smoke and then they consult with marginal ulcer, with perforation. I face these conditions, peritonitis and everything. So what is my question? So just imagine, yes, smoker. And also
Mm.
he promised you, yes, I will quit smoking. My question is, till which time? So you give him for quite smoking 3 weeks, 4 weeks, 1 month, and have you any standard to check, any test for these? Are you routinely do this? Yes, now for this last 3 weeks, any like this, so nicotine in blood, I have no idea. Have you any criteria, any test for these persons before going to do surgery?
Yeah, unfortunately, I think my anesthetist told me once you stop smoking, if the patient are true to themselves, we use some scare tactics, and we do warn them that if there's complication after surgery, smoking is a major contribution part. Most people do promise you and listen to you. And the fact is, once they healed up, sometimes they do go back to it as long as they moderation. So the definition of smoking, apparently, they always say they're light smoker. So definition of smoking is you're a light smoker if you smoke 1 to 2 cigarettes a week. So most people say they are smoke 3 or 4 cigarettes a day. It's very light. That's heavy smoker already. So if you go through a packet a day, I don't know what category you are. So when, as I say, I do a lot of hernia surgery as well. So my anesthetist is a cardiac anesthetist. So I get the best of both worlds. I know that in America, Todd Hannaford and the groups, they measure urinary nicotine level, blood nicotine level, to actually document the fact that if the patients are smoking, because again, if you do complex ventral hernia operations, your risk of wound infection just go up exponentially if you are a smoker, plus age, plus diabetes, right? That's the risk factor. And cardiac surgery, I think I've seen cardiac surgeon cancel people's cardiac bypass. If they are smoker, well, nowadays you get a stent or you get other things, but there are even golden rule that cardiac surgeon apply. So in Australia, I don't think we're that dogmatic in terms of enforcing patients to do tests. We do a lot of blood tests on patients. I'm sure you know, doing all the vitamins, calcium, etc. We haven't really incorporated to that. We encourage them to use a patch, but even the patch sometimes circulating nicotine, probably not a huge problem, but comparatively inhaling nicotine will lower oxygen people's supply, plus about the 6,000 toxins that you're inhaling through your lung. It's just going to make post-operative recovery more bumpy, a lot more coughing, a lot more intraoperative pressures, a lot more unsteadiness on oxygenations, fluctuation of blood pressure, pulmonary pressure as well, which makes the circulation a bit harder. So if you think of physiology, it's very simple. It's just affect everything, including post-op physiotherapy, atelectasis, chest problems, hospital stay, readmission, pneumonia, everything. So I think, smoker, I won't ban them, but you have to look them in the eye, and you have to see, and we usually see patient at least 2 or 3 times, my nurse, my dietitian, everything, and all of us are on the same page to tell the patient and the family. So if they want the surgery really badly, and if the risk factor is high, they need to first take care of what are the bad habits, which is smoking, I think, is one of them. It doesn't matter what surgery you do, even sleeve, even revision surgery, mini bypass, Roux-en-Y gastric bypass, smoking, short-term, long-term. I feel that is worse than asking people not to take any chocolate.
Sir, why I am asking again this, repeating this question, because I know you are one of the person who are decision maker at this globe, especially guidelines and pre-op guidelines, and you're really effective person. So what is my question? Can in future so you are decision maker, So can you add this? So especially in smokers, we must also check nicotine level.
Mm. I think if it's becoming a standard, it will be great. It probably won't stop us doing surgery, but it will allow us to risk stratify patients in terms of monitoring afterwards, in terms of the threshold of intervention. I mean, we all have complications. We all know how to treat it. We all use different way, endoscopically, laparoscopically, the timing of surgery, stent, mega stent, small stent, OCT clips, suturing, draining, washing, everything else. But the key towards complication management, we all know that is early intervention. So if you have a patient that is at high risk, i.e., if they smoke earlier, before, after, if they are chronic smoker, if they got bad diabetes, if during operation your tissues is friable, if they're old age, if they revision surgery, for example, your room or hopefully your resident or your other doctors that to have investigation to these patients if they start having problem is earlier and not having denial problem, because I think I've seen a lot of the world bariatric surgeon, there's always denial problem. You have abdominal pain, or just the wound, you have coughing, you have chest breathlessness, it's just your heart, it's just your cardiothoracic problems. But let alone, it's probably there's a small leaks irritating around the diaphragm that causing you to cough. And there's people that I'm sure you've seen presented with bronchopleural fistula when it's too late afterwards, and the problem become really difficult to treat. But I believe if you pick up the problem earlier and investigated them, the suffering the patients have, the length of hospital stay, the requirement of reoperation, reintervention will be less. So smoking, I think, is a major point to take care of. Would it be a major contraindication? I think in a lot of people's mind that we probably think it will be. The IFSO guideline itself is very broad, and I think you have to be inclusive, as you know, Imran, with all the cultures and all the thing. We not decide to become a police to the patients to take away all the joy of eating and joy of enjoyment. In fact, a lot of my patients now, the joy of that is exercise. And I haven't seen a guy for a year or two, and now he's got six-pack going from 160 kilo to 100 kilo. I never would have imagined that, because the guy in my eyes is never sort of very compliant guy. I mean, I wouldn't want to flag that as he's one of my Middle East cohort patients, but he's now bringing his wife and his family doing his life-changing things for them. And it's a great example that we've seen that sometimes we get it wrong, in a sense that we'll do the surgery on you. We think you may not go that well. I think you're going to get a bypass after the sleeve, but seems to be the sleeve is working well for him. But wait, there's 2 years mark. 5 years, I might be doing bypass on them afterwards. So, but then there's a second step. If I have done a Roux-en-Y gastric bypass on them, they probably will be okay, but maybe more durable, but you cannot reverse and you cannot assess what the sleeve can do first, and then converting them to different type of bypass. That's our view at the moment.
Sir, excellent. Sir, during your discussion, you have highlighted if the patient is suffering with hypocalcemia or iron deficiency or vitamin D. So what I see routinely in obese or morbid obese people, routinely they are, yes, their vitamin D is low, they are iron deficiency. So you don't prefer in Roux-en-Y in such a cases, or no, you just because you have MDT, first you treat this vitamin D deficiency, iron deficiency, then you will go for surgery.
Yes, I think it's been highlighted as one of the problem, but I think it's not such a big problem now, because as I say, anything that is fixable is okay. And I think fortunately we now have pretty good therapeutic people, including endocrinologists, that can help you to treat earlier osteoporosis with injection, bone stimulations, calcium replacement, IM injection, high dose oral vitamin in tablets. And so there's a lot of treatment that we can instigate. So again, it's not exactly something that we will say contraindication, but yes, best to be fixed up. because, otherwise we generate job for orthopedic surgery in the future, which is not such a good thing, and quality of life as well. Iron, as you know, 80% of our patients are female. There's always an issue. Doesn't matter they are premenopausal or postmenopausal. Good documentation and tracking of the iron level is probably what primary physician always do anyway. The first thing the patient come back to you saying that I feel tired. That's kind of the first warning about it. So you go in there, the first thing you check is the vitamins, and the second thing you check is the iron, and the third thing you check is the B12, which a lot of people actually sometimes cannot be too compliant. I think underlying problem-wise, all the other problem, I do see a lot of vitamin deficiency, despite Australia is the capital for melanoma, as you know, because everyone go to the beach in Australia and enjoy surfing. So there should be no vitamin D problem, right? But there is actually quite significant amount of them. Maybe we always think that maybe it's drug companies setting the level of the standard, but I think if we want to fix it, it's easy to fix. But B12 problem, people sometimes can be quite blasé about it. And recently, I think, I'm not sure whether you realize that there's a problem on vitamin B6 toxicity, which is actually a very interesting thing that we discover. Sometimes some of the symptoms that we cannot pinpoint down to vague dizziness and tremors and, fainting and different things can be contributing to too much vitamins, like vitamin B6. So if you start measuring it, certain supplementations actually have over the guideline on B6, and over B6 for a long time and high doses can actually cause problem that we don't remember of. So one hand, you got the deficiency, but the other hand, you got excess. But I would say vitamin D and also calcium issue and also iron issue can be a problem, but it's not such a problem nowadays, unless there is already strong history of every 3 or 6 months they need an iron infusion. But most of the time, there's a hematologist on board already.
Sir, excellent. Sir, really, you are highlighting excellent points, because this is our target. This interview series, we really know, because we know about this, because we have a lot of viewers who are newcomers and they are going to start. This is not only stapling. This is not only just stapling and go ahead. No, this is lifelong follow-up. So regarding this, sir, post-menopause, routinely, these women, they are suffering with osteoporosis. If someone consult you, morbid obese in post-menopause, are you worried about, are you check any osteoporosis, any test for this, and then you go ahead for such a case?
Yeah, I think a lot of the endocrinologists get referral from us from investigation for bone densities and also, DEXA scan, etc., etc. I think you have to realize that the natural process is, if you lose weight, then the body will shed calcium because they don't require a strong skeleton to carry the weight anymore. So it is quite proportional, and hence you've seen all the renal calculi that happening afterwards and kidney stone, gallstone, etc. problems. So it's a natural physiological changes that in fact is welcoming. But the issue with bone is, as my endocrinologist told me, is they can go to overdrive and the osteoclast can become really, really hungry, just like not the patients. We might sort out their GLP-1 and hormonal problems, but the bones become very hungry and start chewing themselves. So that's the stage that if they start getting back pain, aching, a lot of the patients also come to you because they want to lose weight to treat their joint pain and back pain. But if after 3 or 6 months, if you look at the blood test and they start telling you that my pain's getting worse, I'm taking anti-inflammatory, that's another point for anti-inflammatory for you, then you start to realize that, oh, maybe I think there's a bit of overdrive happening. Let's start them to see endocrinologists, if not too early, to stop the bone loss, to save the bone. And they call it the hungry bone syndrome. It's not wrong. So I think my postmenopausal group of women particularly important, because if they have surgery nowadays, quite popular in age maybe 20, 30, even, as you say, hypoabsorptive procedures. And I mean, you can even classify a sleeve as there's an element of reduced absorption of food. And they're going to live through the 20 years later happily, skinny, marry, have children, put on a few kilo, and forget about the whole events on the sleeve or the bypass because they got used to it. And touch wood, you sew up your internal hernia well, they never come back to see you with internal hernia problem, and they enjoy their life. But when they hit menopause, they may realize the rapid deteriorations of their bone density. And these are the time that you need to warn them. You need to be watching out. You need to start your thing early and to replace that. So lifelong supplementations, we do encourage, but unfortunately, as dietitian pointed out, compliance sometimes is an issue. Those tablets are big and difficult to swallow, and it's not the best taste as well. So how do we do that? Maybe we can think of something easier. I would wish that there is once a year injection, something simple. I think people always prefer to take IM B12 rather than oral B12 daily because people forget to take tablets, and it might be mandated that they go to the GP once a year to do this routinely, just like your vaccine now. So I think something in line of that. I mean, in lap band surgery, people used to carry a card saying that they have a lap band, but most people can feel the port. So what's the point? But people don't carry a card to say that I have a sleeve, I have a bypass. Actually, they do. They carry it to the restaurant so they get a cheaper meal. But I think so people sometimes do forget what they have, and they don't remember to tell the physician. So that is my point for long term.
No, really, you have highlighted excellent, because now this is, in my opinion, result of such an interviews. If someone is going to do especially hyperabsorptive surgery, be careful, especially after menopause. So be careful, vitamin D deficiency, be careful, smoker, be careful. Excellent, because when we start our interview, so first we talk about patient selection, then we will talk some technical points, and then we will go ahead with the post-op. Really, I am enjoying, and just I think 1 hour is much less for you, but we will go ahead. So what is your protocol? Pre-op endoscopy for Roux-en-Y gastric bypass.
That is an interesting point, because our fellow just recently returned from training from Michelle Gaillet in Canada, and was telling us that everywhere in the world we do endoscopy before surgery. Unfortunately, Australia, I think we are a little bit relaxed on that. There was no mandate or suggestion or promotions on people that doing bariatrics. And in fact, our fellow has also helped the, if so, we set up the guideline on the investigation on Barrett's, if so guideline on Barrett's and also esophageal cancers. So we had a very good debate, I remember last year, about the incidence of reflux and esophageal cancers. And all the science get bring down in terms of the incidence of Barrett disease and the incidence of conversion of Barrett's to esophageal cancer, et cetera, et cetera. And we realized that we find out that not everyone kind of will develop esophageal cancer. It's probably a bit of an over scaremongering, but there are certain group that will, especially male, smoker, diabetic, obese patients, family history, et cetera, et cetera. So those are people that we would offer routinely endoscopy. So essentially, I think people are more aware in Australia. We're not used to be as much doing routine endoscopy before, during, or after bariatric surgery. But I think it's been highlighted that it really depending on where you work, Imran. I think private practice versus public practice versus access to surgery, and for the young trainee as well, I think having endoscopic skill is a valuable asset. I've seen a number of surgeons in America when we visit that they don't touch the endoscope, they just do the surgery. In my mind, I think as an upper GI surgeon, I don't practice ERCP, I choose that, I can, but we have enough specialty people in our hospital to do that. And these are advanced endoscopic skill which will help you to manage complications. And endoscopy is something simple, easy. You can, if the patients have issues about doing it before the surgery because of anesthetic problem, taking time off, etc. And if they belong to high risk group, you do the endoscopy during the bypass or during the surgery or before you stick a bougie into your anesthesia, stick a bougie into empty the stomach, just to have a look in case you wake up or 3 months later find out that they starting to have swallowing problem, but oh, it's not your stoma, it's your reflux or your cancers. Then I think one of this day, I'm sure this will happen, but we haven't really kind of heard of that yet. But there are more awareness. In Australia, there was no strict guideline. In European, I understand there is. In American, there is, I think. And even up to the state that I think scanning your ultrasound to make sure that you don't have gallstone beforehand as well. I actually would want to ask you a question. What are you guys doing as well? Are you guys enforcing there in Dubai or
No, sir.
Middle East?
No. It's a patient. So it depends on the patient and only in symptomatic patient, because here in Dubai, insurance not covered, and also people unfortunately will resist. But yes, if patient is symptomatic, yes, I prefer to do endoscopy. Sir,
That's
regarding
exactly what the
yeah, yeah.
point.
Sir,
Yeah,
regarding this renal stone that you have highlighted earlier also, if
yes.
someone, so the complaint is yes, repeated renal stone before has past history. Now, morbid obese consult for, but are you prefer Roux-en-Y in such a case or no? No hypoabsorptive view, because we know after Roux-en-Y there is more chance of renal stones.
Yes. I think, most people, I would say that if we choose, Roux-en-Y gastric bypass is only for a few reasons, isn't it? Because either, or I can list the reason for you. One is if patients have seen a Roux-en-Y bypass and it's done really well comparing to his friend having a sleeve, they probably will prefer the bypass, right? The second thing is if we've seen bad diabetic that we think will benefit from the hormonal effect, plus if they have a good C-peptide, which means that they still got reasonable pancreatic reserve, then we'll probably will go for it, and without all the other contraindications. And I think also if the patient is belong to BMI group at least more than, I would say 45, 50 in our range, or male patient central obesity, also suggest that as well, because not that sleeve is easy and simple. I'm sure you've gone through your series already. They're not easy and simple.
Yeah.
They actually have a minor tips and tricks, in my opinion, but it does fit most of the patient. It does give them a taste and a chance of having restrictions and also having some weight loss and see how far they're carrying around. And the beauty of the sleeve is, I'm sure you all know that there's multiple options you can do afterwards. And recently we start doing some study on carbohydrate eaters, especially my Middle East cohort, and have to be saying that it's quite a reasonable outcome. It's only small numbers, but I feel good on treating their weight regain. And another thing is the bypass, we tend to more reserve for patients who end up suffering from bad reflux secondary to previous ban, previous sleeve as well. But one take-home trick on all the youngsters is don't think the bypass will completely resolve your reflux. It all depends on why they're having the reflux. Is it because of a hiatus hernia problem? Is it because of esophageal problem? Is it because of stenosis in the incisura? So if it does, you better make sure the cut is above the stenosis. And also the stoma need to be reasonable small size to allow for easy passage. So I think that's my take-home point of why we do bypass.
Sir, regarding H. pylori eradication, are you do routinely or it is not necessary?
Yes, I think it's important because as we all learn from my predecessors who do a lot of ulcer surgery, vagotomy, which is kind of not essentially dying, but has been lost and forgotten a little bit on vagotomy, truncal vagotomy, selective vagotomy. H. pylori do causes mucosal thinning and defense mechanism, reducing duodenum and more ulceration, so increasing gastric access. And it's easy to do nowadays. Urease breath test, I think the sensitivity is up to about 70, 80%. if you do endoscopy, biopsy, they even nowadays do PCR tests on the resistant one. So you can actually document quite well on how to treat your Helicobacter, and I think it's reasonable. Even there's resistant on HP7 now, up to about sensitivity is only about 90%, but I think it's a reasonable thing, simple, that we can do as part of the blood test as well.
Thank you, sir. Sir, now, because till this time we discuss about pre-op or patient selection, and also you touched some technical points. You highlighted the size of your gastrostomy. Already you have touched. So, but two things that I like to hear from your side, that is the BP limb, the size of BP limb at initial surgery. We are talking now, not redo. In initial surgery, what is your BP limb size and what is the size of your gastric pouch? One question, and also, is this gastric pouch size is effective? So if size is less or more on weight regain and also marginal ulcer?
Yeah, that's a very interesting, because when we first learned of gastric bypass in America, we using the same sizing bougie as we do for sleeve. So essentially it's 36 French, and I strongly believe the gastric pouch shouldn't be longer than 2 to 3 firing, because otherwise you have a long pouch. But in some instances, I'm pretty sure you also know that the mini bypass that you do supposedly is from the incisura. So the stapling is actually much longer comparing to the gastric pouch that we do for Roux-en-Y gastric bypass. But sometimes you may choose a little bit lower based on the size of the patient, the tension you have for small bowel. And when we first started Roux-en-Y gastric bypass, we were told that I think your BP limb probably should be about 60 centimeters only, and then you're bypassing a meter of bowel on the alimentary limb before you reach the common channel. But it's been documented through recent publications, and also in our technique changes now with BP limb, we're moving on to about 100 centimeters, and the alimentary limb to about approximately 80 or even 100, depending on the BMI. So that kind of work a lot more efficient for us in terms of both the easiness of the mesenteric fat, because you don't have a bypass if you cannot physically pull up your small bowel to the pouch. So that's one thing. So the first thing you go in for the youngsters to check is, don't be focused very enthusiastically on saying that let's make a perfect pouch. Because if you make a perfect pouch afterwards and you find out that your small bowel cannot reach, you're going to have tension issue. And do you want a leak in your hand? The answer is no. So you do want to suturing on something that is full of tension. That's the number one no for surgery, right? Vascularity, suturing technique, and tension. So these are the three things that's important. So moving the BP limb a little bit longer sometimes actually allow us to have the mesentery in a more relaxed way to going upward as well. So you tailor your pouch size a little bit based on what surgical technique or tension you have. But I share your point that gastric exit, the more pouch you have, the more exit you have. But that's a variable factor. That could be age dependent, that could be diabetes, and also medical dependent, H. pylori as well. So I think you make a standard size. Most surgeons tend to have a standard way of doing operations, and we size it along a 36 French, 2 to 3 cartridge, starting above the incisura. And we don't take the left gastric because you don't want to supercharge your pouch. So we go around the edge, 1 staple, and then 2, 3. The last shot, I usually use seam guard to reinforce the top end, even if it's revision or primary surgery, because it's just the one less chances that you can have a leak somewhere, because being bypassed, you can have leak anyway. Stomach remnant, top end, your anastomosis, your GJ, everywhere. So the less chances you have, the better it is. But that's how we do it. And the technique itself, as I told you, that now we have no problem using 3.0 PDS V-lock, as long as you know how to use it. You just take, not that because we cannot tie knot. We can tie knot because we come from hand-sew era. But I think we encourage the youngster to do a mixture of them beforehand, because if you run out of V-lock or some stage V-lock cannot be helpful or valuable to you, you have to go back to your 2-0 or 3-0 monocrystal hand sew, and you got to learn how to tie a knot well and securely, because that's just the basic of surgery.
Sir, as you have mentioned, so definitely your pouch is longer than routine.
Not longer, but 2 shots, probably approximately about 7-8 centimeters, because the longer it is, if you listen to VJ Lee's mini bypass surgery, that he actually do short long, the mechanism of the restriction is not just your stoma size, it's your size of your pouch. So wider short pouch, unless there's a problem with previous lap band up the top and you don't want to muck around with the scar tissue, your pouch need to be sizing according to the bougie. And if you find a hiatus hernia, I would suggest you to actually fix it, because that can also be a problem in the future for you. But you can always come back and fix it if the patient have no reflux.
Yeah. Sir, if we go before PPI era, I remember at that time, the main issue was peptic ulcer, and many times, so there was surgical intervention, okay? And one of this was vagatomy and maybe highly selective, or I have no idea, truncal. So, because now in Roux-en-Y gastric bypass, RNY gastric bypass, one of the main issue is marginal ulcer. There is no doubt. Have you any experience, or what is your opinion about vagatomy? Is it
yes, I think we have done a few, but I think mostly if they have ulceration, I have 2 patients that, we don't have much time, but I have video of eye excising the ulcer and redo it again. And your liver is your friend, because the ulcer actually stuck to the liver and stopping it from perforating. I was very interesting to see. And when you go back in for intractable ulcer and think, just one more thing you can do, vagal nerve dysfunction, if you take you at least have to take 1 trunk, because I think mostly people will take the anterior trunk, because posterior trunk can be a little bit hard to access. You have to go underneath, but I think selective vagotomy kind of doesn't really cut it during the time of the stomach pouch, if you already have a marginal ulcer, or if you go back in to repair hiatus or whatever reason it is. And I think you need to at least take 1 trunk of it to be safe. But there's a lot of therapeutic thing we can do for patients, high dose PPI, sucralfate, and a lot of other medical therapy we can instigate, and also stop smoking if we stop. Yeah.
This is so excellent, sir. So regarding PPI after surgery, how long time you prefer and you suggest your patients?
I think at least about 6 months. That's my routine. In Australia, we recently just have been regulated in a sense that people used to take 40 milligrams of PPI as a routine, let's say Nexium, and some gastroenterologists even prescribed 120 milligrams. And now the government actually enforcing that 20 milligrams is just the standard dose. Anything more than 20 milligrams, we need authorities. I'm not sure whether it's economic problems or costing them too much, or whether it's something scientific, but I believe it's actually scientifically saying that it's not about toxicity, because there's that big German study talking about PPI causing dementias and also other issue, which can be a little bit difficult to interpret. But most patients are saying 20 milligrams of PPI in 6 months doesn't hurt them, and they can then go on and off of it depending on symptoms.
Sir, yes, so much thanks. Sir, another issue that is internal hernia after Roux-en-Y gastric bypass, and that is really nightmare for patient, also for surgeon. So have you faced this internal hernia, and during this your journey of bariatric surgery, that is now about 16 years. So definitely you have changed. Are you, first of all, are you close the defects? One question. And when you have started to close, from first you have started, or no? Initially, you will not close, then there was internal hernia, you have started, and what is the result? What is the difference?
Yeah, unfortunately, we always been brainwashed by the American. We've always been closing it. I understand some of the surgeons don't, and there's even suggestion now, even some people will close the defect between the colonic mesentery and the small bowel mesentery, even because there's reported cases. I have 1 or 2 cases of mine, the bowel just go this way. doesn't matter, it's a single anastomosis. So Roux-en-Y gastric bypass, I think we routinely do that. I believe, especially I think the enterostomy side of the sutures definitely should be done at least, because that's an easy thing to do, or relatively easy thing to do after your enterostomy. But you have to be careful, kind of in a way that you don't fixate the small bowel that is causing you a kink, because so many situations we've seen that people are overzealous and suture it up to the maximum, and then you realize your elementary limb is kind of, when it hit the BP limb, especially their hand sole with a small caliber lumen, that you're going to cause an obstruction there, or if you double stapling, you already have slight narrowing, and then you kink it further by closing the internal hernia. So it's got a balance, but yes, you should suture it. That's one thing with non-absorbable sutures, tack, whatever people use, right? The defect between the elementary limb mesentery and the colon, the Peterson space, I wouldn't say it's debatable. That's a little bit more hard to deal with, because it's not friendly in a sense that there are patients that we found that with vague pain and colic and constipation, it's not relating to the fact of internal hernia, it's relating to some surgeon that I've seen other people's that they're closing up too narrow, and essentially the whole elementary limb just crossing the colon like that. So you're causing a bit of colonic obstruction. So, well, unfortunately, these people often end up seeing the colorectal surgeon rather than us. And then the colorectal surgeon find out and say, hey, there is something around the transverse colon that they can't get through. and then they realize that, probably the patient has had a too good closure of Peterson space. So there's a natural space that when patient weight loss will develop in a bigger way anyway. So I think we have to be a balance, and that the defect is the first thing to go for if you have any CT evidence afterwards of the small bowel not being in a good positions. So this is something that, and we have seen a couple, fortunately, maybe someone else is treating my bypass internal hernia. When you count from your terminal ileum backward, usually you can revert them. But there are cases that if the bowel is too twisty, even 1 round, 2 round, you end up requiring small laparotomy, because this patient typically would have lost good weight, because this problem usually is a chronic, and sometimes a bit of laparotomy help you to orientate yourself much better, just like when we do cancer surgery with the Roux-en-Y arrangement with total gastrectomy, same thing. But that tend to be retrocolic rather than anticolic.
Sir, it was interesting. Have you faced any colonic obstruction due to ruling in your patient?
Not fully, but we realized that patient with symptoms like that. I have one patient that from another surgeon that come back, we have to go in and release a couple of sutures to make the colon a little bit more mobile. And then she told me that the symptom of constipations has resolved. So because initially they also worry about cancers and strictures, narrowing, and it's been demonstrated through barium swallow and things. So I'm not saying you shouldn't close it, because most of the hernia from there, you need to take care of it, but it's got to be a balance between how much space you leave for the colon to go through.
Yeah,
because most of us do anti-colic.
Yeah, sure. Sir, so now in 2022, which percentage of your bariatric surgery belong to Roux-en-Y gastric bypass?
I would say if I mixture of my 400-500 cases a year, I would still say about 70% is sleeve. It used to be about almost 80%, but we're doing about almost 30-40% of bypass now. So it's creeping up. You go from initially a lot of band to, and then a lot of sleeve, and then now the bypass coming back a little bit more based on the treatment of weight regain, reflux, and then primary surgery, etc. And then you get into the fact that I'm talking about bypass of different bypass, like single anastomosis, Roux-en-Y, and even SADI. I call them a bypass as well. Not many people doing the hardcore BPD in Australia as such, but that's my practice. Yeah.
Excellent.
Plus endoscopic now 10%.
Yeah, sir. Now, because you are also expert, not only you are a surgeon, because as I know very well, You are leading person at this globe, especially at the platform of IPSO and many other so such an organization. So you hear also, you watch also, you have practice, you know. So what is my question? What is your main concern about RNY gastric bypass now? So you can see more than 3-4 decades. If we see from, we start from open surgery, so then we start, and now in 2022 we are here. What is your main concern?
I think the main concern with Ruan, why, I mean, you, besides what we've been going through just now in the past hour about all the different issue, is that all the surgery run out of longevity. So if you have a good relationship with patient, which most surgeons I believe do, because they become your good friend, family friends, or, you know, they bring the whole family to you, they trust you, they will come back to you for options when there's weight regain. So marginal ulcer is one problem. Weight regain, we feel that is difficult. We haven't even get into the debate about using the ring or not. I'm personally, I have to declare that I don't use the ring as much, even though there's good publications. I mean, it's not just the additional cost, but it's just the thing that I've seen in our center that have rings that coming out for different reasons. So it's becoming like a band that going in and out for more operation, and the ring erosions and etc. that happen, trading on the fact of so-called good durable results. So when patients have good weight regain, what is your option afterwards? Are you going to lengthen the BP limb? I will try endoscopically to narrow the stoma first, because that probably could be one of the factors that is not long lasting. Would you go in to make the pouch smaller, do more bypass? It depends on what the calcium, iron, and what the other nutritional parameter, depending on the diabetes. So what sort of option do you have afterwards? That's the issue. If you lengthen your enteroenterostomy, I mean, i.e. you lengthen your BP limb joint to more distally to induce more hypoabsorptions, then are you going to run into more problems? Is there any going to be more mesenteric issues and internal hernia problem? Whereas comparatively, sleeve had option, even single anastomosis bypass have option to move to divide the BP limb, convert to Roux-en-Y bypass, possibly at a ring, whatever you want to do afterwards. But the Roux-en-Y gastric bypass kind of the one shot, maybe a little bit of adjustment afterwards. So that bit, it's not that I'm reluctant to do it. It's a great operation. Now you master it, and I encourage surgeons to really delve into that and learn about it. It's got a lot of history, a lot of science to it. That's where all we started. And but that's the issue. The Achilles heels is that when there's weight regain, patient come back, or either from you or other surgeons, what are you going to do next?
Yeah, so
medical therapy.
Sir, I can't believe now we have crossed 1 hour, and really I am interested, and still our question is remaining. Definite. In future, I will disturb you, and we need your support. Sir, your message for our youngsters.
I think the message for youngsters is after we finish COVID, which has been ravaging us either, you know, sort of case-wise, psychologically, economically, causing enormous damage to our health and our patients' health. And all the evidence are out there that patients who are sicker, obese, get more complications from any diseases. Like, you know, diabetes is something that we're fighting for, but you see COVID doing to the world. Bariatric surgery is not going to go away. In fact, we need more bariatric surgeons. There's more patients we can handle. We should stop fighting about which procedure is the best. We just have to learn about the different procedure and try your best to offer the operation in the safest in your hand, safest in your hospital, without causing too much of patients' hospital, and also how to treat complications early, because that you know, you have to accept the fact most of the youngsters, when they face their first complication, I think a lot of people thinking about commit suicide because it's very traumatic for them. And it's not nice to see patients suffer in your own hand. But please learn the fact that I think if you go through it carefully, your complication will be minimized. And complication is not normal, but it can happen. And so don't be harsh on yourself, and don't stop doing bariatric surgery because of the, how would I say, because of the hassle and the complication. You're going to get happy patients coming to see you. It will make you feel good. It will be very fulfilling. And the more surgeon can do proper surgery, the better. And hence, Imran, I very commending on your group to try to another way to promote surgery. I know that in my now life, realizing that I think after 20 years of surgery, we've done enough operations. So we need to have succession planning and help other surgeons to not to replace us, but to help to promote the operation and make it safer. So I thank you very much for giving me the opportunity to share my opinion for you.
Sir, it is really great honor for me, really great honor for me, and also GLR platform. We are also facilitating our youngsters for fellowship program. Now we are affiliated with Madrid University, with Napoli, Mario Mozzella, CK Huang, Talibpur, Hessam. And sir, it will be great honor if we have such an opportunity, and I will stay in touch with you because we have lot of CVs now in my account I have. And you can't believe youngsters from Ecuador till Egypt and many other countries, they want to, because this, as you have mentioned, so this skill, this expertise is very important. And person like you can support us, you can support GLR, you can catch the hands of such a youngsters. And definite, sir, I will stay in touch, and we need more your support and guidance.
Yeah, no, that's exactly what happening in Asian Pacific as well, because a lot of countries are starting to do surgery. When I first started, if so, APAC is only about 4 or 5 countries. Now it's grown to 10 countries. And I think we're just going to see it better. And I was very looking forward to come to Alcoba, but I think now it's going to be May. So I think we actually have a few Saudi fellow in our hospital as well. And they were saying how advanced you guys are and how adaptive in the thinking that it is. It's really lovely to see. And
sure.
And I'll be able to help whatever I can. And we stay in touch, please.
Sir, it will be great. And Harit, so much thanks, my viewers. Till this time you are here, and from India till Middle East and Europe. And I know Professor in Australia now there is 5 a.m. I think, and we started
6 a.m. now.
6 a.m.
Yeah,
we started 5 a.m. Really so much thanks, sir. And we will continue this series of Rohan gastric bypass. And next week, Tuesday, 10 p.m. Dubai time, we will be with another expert of Rohan. We will continue this series, interview series, till June 2022, and then we will have some obsession. After that, we will go ahead with the metabolic patients with low BMI, with metabolic syndrome, sleep plus surgeries. And then in 2023, we will talk about redo surgeries. Sir, so much thanks for your time. And definitely in future, we need your support and guidance.
Thank you very much.
So much
good
thanks,
morning,
sir.
Good night for you.
Thank you, sir. Thank you, sir.
Thank
Have
you.
a nice day.
Bye-bye.
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 Thank you, sir. Thank you, sir.